All right, well, welcome to Garnet Health Self-Care Forum series. This month's topic is in honor of Heart Health Month, and we are talking about women's health. I am joined this evening by a panel of medical professionals. Christina Hahn is a family nurse practitioner for cardiology at Garnet Health Doctors. She obtained her bachelor's degree in nursing from Seton Hall in South Orange, New Jersey, and she obtained her master's degree in nursing from Columbia University School of Nursing. Dr. Linda Cuomo is an interventional cardiologist at Crystal Run, and she obtained her medical degree from the University of Buffalo School of Medicine and completed her residency, internships, and fellowship at the New York Presbyterian Hospital, Cornell Medical Center, and New York College. Mary Kate Donahue is a nurse and an administrator of cardiology services at Garnet Health Medical Center and Garnet Health Medical Center Catskills. She obtained her nursing degree from Mount St. Mary College and is currently pursuing her MBA. So, according to the CDC, heart disease is the leading cause of death for men and women. Our first steps towards heart health is becoming aware of your own personal risks for heart disease. What are some traditional and non-traditional risk factors for women? I will put it to the panelists.
Who wants to take it? You want me to take it?
Sure.
Okay. So the traditional cardiac risk factors we generally talk about are smoking, diabetes, high blood pressure, high cholesterol, family history of early coronary artery disease. Those are, kind of the 5 traditional risk factors that apply to both men and women. Specific risk factors that apply to women is a personal history of preeclampsia with pregnancy, a history of polycystic ovarian syndrome or PCOS, or a history of gestational diabetes. Also having a history of underlying autoimmune conditions such as lupus and rheumatoid arthritis, which tends to happen more in women, are also risk factors for cardiac disease, like early coronary artery disease. So those are kind of the usual ones that we talk about.
All right. You had mentioned cholesterol in there. What are some things that you can do to reduce your cholesterol?
Christina, you want to jump on that?
I'll jump in. So cholesterol is heavily genetic. So there are things that you're born with, and then there's things you can do. So some of the same risk factors for heart disease also are the risk factors for high cholesterol. So things like smoking, having hypertension, and family history are all important. But those are things you kind of can't control always, but the things you can control is making sure you stop smoking, maintaining a healthy weight, and eating a healthy balanced diet as unprocessed as possible is really the way to go.
Yeah, and one of the other things that you had mentioned there, Dr. Cuomo, was hormones like pregnancy and PCOS. Do you guys mind expanding a little on that?
So a lot of this stuff is not 100% known why this happens. It's thought that, if people have problems, say, for example, with pregnancy, so if you have preeclampsia or gestational diabetes, that's the first time that your body's put under tremendous stress as a woman. And if you have a lot of blood pressure issues or problems with your sugar, it has been shown that if you follow women who have it, they're more likely to develop high blood pressure at a younger age or more likely to develop diabetes. So those are things to kind of watch out for. Polycystic ovarian syndrome, they're not exactly sure why it increases people's risk in it, but it just has an increased risk. Now, they're not the same magnitude of someone who smokes, so it's not to the same degree, but it definitely kind of weighs in when we're seeing someone. So, if you see someone who doesn't have any of the traditional risk factors, but then they tell you they had 3 pregnancies, they were all induced early for severe preeclampsia, they were kept in the hospital. Those are people that your ears perk up because you're a little bit more on edge when they tell you that with regards to their symptoms.
We also talked about this the other day, like PCOS is an example of an autoimmune disease, and women with autoimmune disease, well, anybody with autoimmune disease, but especially women with autoimmune disease are at higher risk for developing coronary artery disease. So patients who have some pre-existing autoimmune disease, when they kind of turn up in your office with some concerning symptoms, you're more likely to just move ahead with stress testing and things like that because of that added risk.
And it also plays into like, my decision-making on how aggressive I am with patients and with regards to management. We touched upon this the other day as well. If you see a 50-year-old woman with lupus who has an LDL of 140, you're not going to tell her that's okay. Where a primary care doctor may say, you know what, oh, your cholesterol's a little bit high, work on your diet. But as Christina mentioned, unfortunately, and people don't want to hear this, so much of cholesterol is kind of genetically kind of determined. You have people who eat horribly, fast food, morbidly obese, and they have beautiful cholesterol panels. And you see they'll go, oh yeah, my whole family has high cholesterol. So there's definitely, like, we make a lot of cholesterol, and a lot of that's predetermined. So when people go, oh, I'm going to work on my diet, unfortunately, unless you become extremely plant-based, like 100% vegan, and sustain that, it's very hard to make massive changes in your cholesterol that we need to see in cardiology. So that it's really important to understand how we make decisions and why sometimes we push things a little bit harder than some patients would like in terms of medications, because we feel that they're at higher risk and we know that lifestyle is not going to be enough for them.
Right. And we discussed this yesterday or the other day as well when we were talking about it, just making sure you don't get wrapped up in just the numbers and you're seeing somebody that's looking at the whole picture and developing a relationship with a provider that you really trust, that can look at you holistically and not just look at a couple of numbers.
Yeah, I actually have a really good example from the office. I had a patient who brought in her daughter who was like 20 something, and she's like, she has hyperlipidemia like me. I just want to see what we should do. The daughter was like 20 years old and had an LDL of 115. And I was like, this is okay. We'll keep an eye, blah, blah, blah. And the mom said, well, mine is 120 and I'm on Lipitor, so she couldn't understand why 120 was high for her, but not high for her daughter. And after some talking, we realized that she's already had, the mom, some coronary disease. So I was like, this 120 isn't the problem. Your LDL is not bad. It's that you have coronary disease already. And that's the difference. So sometimes people, like you mentioned, Mary Kate, can get really wrapped up in the numbers, but it's actually about the whole picture, if that makes sense.
Right. And also, with regards to the numbers, we target people differently, right, when we treat them. So, right, the 20-year-old, her LDL 115, 130, you're going to be like, okay, this is a little bit high. You need to be careful. You need to be mindful of what you're doing. Versus someone with coronary disease, if you look like on our lab, it says LDL less than 130 is considered normal. So patients come to me and it's not flagged then, right? So it doesn't have the star or the high next to it. So people go, oh, but my numbers are fine. But once you have coronary artery disease, the LDL goal is less than 70. I mean, that is an extremely strict LDL goal. And that's almost impossible for most people to get to without a medication. And people don't, it's very rare to see someone walk into your office with an LDL of 60. I mean, it happens, but it's just not common. So, and that's what's been shown in studies to maximally reduce your risk of having a heart attack. So I always try to explain to patients, it's not just that you don't want their numbers to look good on paper so things aren't starred and don't have H and L next to it for high and low, but it's more what those numbers mean for you as an individual in your risk and what we can do to minimize that risk.
For sure. I'm not sure which one of you guys said it, but you did say or mention about stress. And I mean, we're women. We carry the weight of the world on our shoulders, moms and wives and everything like that. Is stress a risk factor?
For sure. Yes.
She's shaking her head.
Definitely adds to risk and also can add to eliciting your symptoms of heart disease. So a lot of times women are kind of told like, oh, it's you must be having anxiety that you're experiencing, or stress, you know, it's all the stress in your life. But when you're under emotional stress, you can have real cardiac symptoms, and it's not just the stress, it's the stress eliciting it. So stress is, the way we feel under stress is important to pay attention to.
Right. It's been shown that women are more likely to have chest pain under emotional stress, as opposed to the typical chest pain that you think about when patients are having, you know, chest pain from their heart, or what's called angina or angina. Typically for a man, that's more related to a physical stress. So they go do something, they exercise and they get pain, and it goes away when they rest. That's more typical for a man, where a woman is more, women do get chest pain. They do often get chest pain, but they're more likely to chest pain at rest or under emotional stress. So they'll go, oh, I never have chest pain when I exercise. I'm fine when I exercise. Just when I fight with my husband, or I'm yelling at my kids, like my chest gets really tight. And then it goes, oh, just you're anxious, it's life. And, you know, people get blown off for that. That is clearly been shown that that's where women show their chest pain much more so than with physical activity.
And women are far more likely to ignore it, especially during those times.
Exactly. Because
I'm fine, it's fine.
I can go to the gym, I can exercise, I'm fine. It's just when I'm mad. So you think it's just that. And listen, most of the time it's not anything, but you don't want to ignore it and assume everything is okay, because it's only happening when you're upset.
Yeah, the other thing that we hear a lot with women, especially they're missing coming into the office for this, unfortunately, and we see them in the ER. They come in. How many times have y'all heard this? I have really bad reflux. I'm here for my reflux. It's really bad. And I'm like, oh, well, how long have you had reflux? You know, oh, years and years and years. Do you take medicine? Yeah. Does it help? No. You know, I take my Protonics and my Tums religiously, and it doesn't help. And, you know, we're unfortunately breaking the news that it was probably never reflux, or maybe you have reflux, but that's not what brought you to the ER. It was actually angina. And sometimes it doesn't always feel like crushing left-sided chest pain like we learn at school. Sometimes it can be a burning sensation in your chest, even in the middle of your chest, and even it can be associated with belching or burping, and people think that it's reflux, but it's actually chest pain.
Especially when they consider an age, or they put a number next to that pain, right? So a lot of women think they're too young to be able, or to be having those types of symptoms. So it's easy to attribute, or it makes more sense logically to attribute it to something GI related instead, or just stress.
Right. Or maybe even a doctor has told us, you know, in the past, oh, it's, you know, it's reflux. But when it's persistent, and if your medicines don't work, keep going to the doctor.
Right. I mean, obviously there's something, you know, with GERD or reflux, it typically has a, you know, a brought on by spicy meal, a large meal, wine, you know, laying down in bed after a meal. Those are, you know, that reflux is more typical, where you can really find the trigger. When you see the patients coming in with the heart attacks, with the burning and the heartburn, it's just coming out of nowhere. I mean, they're just, you know, it's there, they're sitting there, just, you know, a sudden onset, nothing to do with a meal or anything they've eaten or drank. That's highly atypical for reflux from GI issues.
For sure.
Wow. Yeah. I don't think I ever really think about heartburn, you know, being a symptom. Is that unique to women, or is that common?
It's not unique. It's just more common.
It's more common.
So women, both men and women, generally, the most common symptom of heart disease, a coronary artery disease, or, you know, blockages in the arteries, or a heart attack, the most common symptom universally is chest pain. So and both men and women feel that. It's just that women are more likely not to have chest pain when they're having a cardiac event. And they're more likely to have more atypical way they're describing it. They're more likely to have associated kind of GI symptoms like burning or nausea. And they're often very much will say, I just feel tired. I just don't feel right. Like just very kind of non-specific. And I think, you know, it's unfortunate, but like the classic teaching, even when I was in medical school, which, you know, was 20 years ago, was always this classic presentation of this like man clutching his chest, the elephant on his chest, you know, falling to the ground. And listen, I've been an interventional cardiologist for a long time. That's not the way the majority of people are when they're having their heart attack. They say it hurts, but they're not really in absolute agony like someone with pancreatitis is, right? So, but then you take a woman, they're usually kind of like, well, I did this today, and then I did that today, and then I felt this, and then I was tired, and they just kind of go on this like long stories. And I think people often, you know, just don't really hear things that they think are heart, and they may not get an EKG because of that. And you know, there's a lot of delays in women's care because of the way they describe their symptoms. And a lot of that's because of kind of lack of knowledge or misinformation, which, we're trying to, change, but there's still a lot of people who think the 50-year-old women don't have heart attacks, which is just not the case.
Absolutely.
Or I think we said it along the way here too, but smoking, smoking is a big topic.
Yeah.
Let's
smoking is huge because women, one thing, smoking is horrible, obviously, for, a ton of different medical issues, but smoking is, a major risk factor for early plaque formation. It's a major risk factor for plaque instability. So when someone has a heart attack, that's due to, most of the time it's due to blockage or plaque that's there. And then that plaque becomes unstable and you get plaque rupture, which is the physiology behind a heart attack. And people who smoke are more likely to have that. And unfortunately, women, we've seen studies where the amount of women smoking is increasing. Women like to smoke to keep their weight down. And so you'll hear people don't want to quit because they don't want to gain weight. And so smoking is a huge problem that is, completely modifiable, right? That's something you 100% control. You can't control your family. You can't control your cholesterol. Sometimes blood pressure you can't control, but the smoking you have complete control over.
Sometimes when I see patients in the office, we were just talking about like who goes on cholesterol medicine and not. There's something we use called an ASCVD risk score, and a lot of times with my patients who are smokers, I calculate their ASCVD risk score, which tells us the likelihood of having a major cardiac event over the next 10 years. So I'll calculate their ASCVD risk score. I'll show them it's high, it's pretty high. So they have a pretty high risk. And what I'll do is take away smoking and show them how drastically their numbers go down. So that's a 10-year projection. And like Dr. Cuomo said, there's a lot of things that are non-modifiable, like your age and having hypertension. Those aren't your fault. But if you can get rid of smoking over 10 years, your risks are going to go way down. And that's, it's not an easy fix because I know how hard it is for people, but it's a necessary fix.
Yeah, that's a great one. If you can fix it easy, right? I will plug real quick that Garnet Health does offer a freedom from smoking program. So if anybody is interested in smoking, we do offer support with smoking cessation. Smoking, though, one of you mentioned helps with weight control, right? So what effects does weight have on your heart? And what's a good diet? There's always these great diets out these days.
All right. Okay, I'll jump. Christina, okay, you can talk, Christina.
So I kind of mentioned it before, but there definitely isn't one straight answer for the ideal diet or the best diet. So although there are some that are better than others, I generally just ask my patients to eat as little processed food as possible, which is tough. It does mean more cooking and more preparing, because I think that if you're not sure, the safest way is to make your own food, which I know is hard. But I definitely disagree with any sort of fad diets, anything that cuts anything out, anything that's well balanced and diverse is best. And we know that being overweight increases risk for heart disease, diabetes, high blood pressure, among a multitude of other diseases.
Yeah, I think like we talked about the other day, a lot of these fad diets, like, keto right now, keto is the big fad diet. These diets that, as Christina mentioned, that are restrictive in one, area, so you're not eating any carbs, you're eating all this fat, you see the cholesterol panels of some of these people doing keto, and their cholesterols are really high while they're doing that. And that may be okay for a 20-year-old, but when you're 50, that's not the answer. And then the other problem with these fad diets is that the overwhelming majority of people who do them, they end up gaining the weight back and then some. And that's been shown over and over again. These, everyone wants the diet where you lose 5 pounds in a week, right? You don't want to lose a half a pound a week. That's not, you know, as nice to see. It doesn't make you feel as good, right? When you step on the
gratification.
Right. So people love these fad diets because they lose weight quickly, but then once you start to go back to eating, you gain the weight back. And it's been shown that this yo-yoing that people do is as bad as just being not, you know, it can be as bad as just being heavy. So if you're going to lose 20 pounds, gain 30 pounds, and lose another 40 pounds, that's not good for your heart either. You know, it's more about making, you know, people ask, you know, Christine's gonna say the same thing. We get asked that diet all the time. People say, well, how much of this can I eat? And how much of that? And I'm like, it's not about that. It's about understanding food, reading labels, and trying not to eat out, trying to prepare your own food, trying to eat, you know, less processed food, and make lifestyle changes that are gonna stay in place for years to come. You know, I've had a lot of people lately using Noom as a weight loss, you know, the Noom app. And, you know, and a lot of women say the reason they really like that is they like the counseling aspect of it. They like that it helps them understand the emotional eating that a lot of women do. And so they're not, you know, I had a patient yesterday I was talking to, and she's lost 40 pounds in a year. So that's, you know, but she was, you know, very, very heavy. So 40 pounds in a year is obviously excellent. But she's only losing like a pound every couple of weeks, but she's using Noom and she's really understanding why she's eating, and she's making smart choices now because of that, as opposed to just saying, I'm only going to eat, you know, 1,200 calories and not eat any of this.
Yeah. I definitely, we don't work for Noom, but I've had a few patients have good results also. And I think that's because of the freedom that you get, like, because like Dr. Cuomo said, I don't like to remove any certain thing from diet, especially A, that doesn't work, and B, it doesn't have longevity. You know, if you like love a certain food, and if someone tells you can't ever have it, you're not going to stick on that diet for too long. So yeah, anything that lets people have a little bit more freedom and autonomy. And when patients are just really starting and really kind of feeling lost in the grocery store and what to do, I ask them to try to just focus on one meal at a time, like one meal per day, like which is the meal that maybe you're home for and is easier for you to be more involved in, because maybe they're so busy at work they can't imagine. So maybe they can focus on either breakfast or dinner, and really just get some options going, do some Googling for some recipes, and kind of feel really good and comfortable with their healthy options for that meal, and then maybe move on to another one. And that sort of slow process is going to help build habits that last a long time, and it's going to lead to slow, consistent weight loss.
I've heard the same things about Noom and how it even focuses on things like not having to finish everything on your plate, which we were taught, like as children, you can't leave the table, right, unless you finish everything in front of you.
Right.
And how Noom really talks about just eating until you're full. But the other thing that I've seen that's really great is the ShopRite app. So anybody that does their shopping on ShopRite, they have a recipe section that's really, really easy, where you could just add all the ingredients to the cart, and it lists all the nutrition information. Yeah, and actually, like, I use it all the time because
that's so cool.
Yeah, it's easy for me. So it's easy for meal planning. It's easy when I'm like running around picking up my daughter after school. Like it's easy. And there are a lot of healthy options. I mean, they work with a dietitian. Our Healthy Heart program works with ShopRite, has always worked with ShopRite and the dietitians at ShopRite. So they are very familiar with encouraging, you know, their consumers to shop wisely and make smart diet choices.
Oh, that's
ShopRite. I didn't even know all that. That's awesome.
Yeah, me neither. I know about the dietitian, but I didn't know about the app.
Yeah, no, the app is amazing, and you can also just put in your order, and you can set up like a time to come pick it up, or they deliver it at home. So what's great about these recipes is you can click one button and add all the ingredients to the cart.
Without ever walking into the chip aisle.
Right, exactly. And making it past the ice cream and not even
Smart. I like it.
Yeah, for sure. I'm going to have to look at that feature. I do like the shop from home, the shop right from home. So our forum is about self-care. So we are doing a ton of education here on, you know, heart health in general, but what are some preventative things we can do to live a heart healthy, heart disease free lifestyle?
Doing it completely free is tough because of the genetic component. And I want to get to the point that you were trying to make, but I want to add that a lot of times patients of mine, especially women, when I mention starting blood pressure medicine or cholesterol medicine, somehow view it as a personal failure.
Mm-hmm.
And it's not. And it's really hard for them to accept that it's not. You're not here today starting Lipitor because you didn't eat enough kale. Like, it's not your fault. You know, there's a lot you can do to minimize your risks over time. Some of them we touched on already, but shy of get new parents.
Right.
Who can't
aging or not aging, right? It's
right,
aging.
right, or not age, right? And if you
Right.
figure that out, please, we'll be happy to hear that in this exact forum. But I just want people to understand that you can do everything right, and by doing everything quote right, like not smoking and eating well and maintaining a healthy weight, you are dramatically lowering your risks. But your risks are your risks, and
right.
that's the cards that you've been dealt. And there is no personal failure involved with taking the medicines you need. And for some reason that's felt with heart disease, and it's not felt with something like cancer, right?
Like breast cancer, for example.
Like breast cancer,
yeah.
right? People
right.
know that's not, in most cases, it's not their fault, right? It's genetic, and they know that their mom had it and their aunt had it, and doctor, I'll take whatever you want me to take
right.
to make it better. And heart disease, which is significantly more deadly, there's a lot more personal reservations about it. So if you get high blood pressure and if you get heart disease or whatever, do everything you can to reduce your risks, but do that in conjunction with the medicines recommended by your doctor. And it's okay. I promise.
Right. And going on that, I mean, I have people tell me all the time, but I did everything right. I didn't do this. And I say, yeah, right. And if you didn't do all that, you would have been here 10 years earlier, probably. Right. So
exactly.
To what you're saying, it's risk. And no one, when you're 60, your risk is not zero. And that's a fact. That's the problem. You can, the risk factor, the risk that Christina was talking about that we use, you don't get zero for anybody, right? The percentage never says you're 0% risk
right.
for having it.
For a young person, it's like 1%.
Right. So you're always at risk. It's just a question of who's more at risk. So if you live a heart healthy lifestyle, you exercise, the American Heart Association recommends, 120 to 150 minutes of structured exercise a week of aerobic activity. So you exercise, you don't smoke, you eat well, you do all of that. You're still going to have a risk by nature of in getting older and by nature of some genetic components of what you've inherited. So, right, it's not a failure, exactly what Christina's saying. And one of the things that I find very challenging, you see it all the time. No one wants to start that first medication. So anytime you're the person who tells the patient, you have a chronic problem and now you need this medicine indefinitely, they like freak. They don't want to take the medicine. And
they're like, for how long?
They always say, for how long? Well, when my blood pressure gets better, can I stop? No, that's not the way this works. Both men and women have their reservations, but I think we feel things more like, oh, I failed, right? Because I think we're made, right? But then when you look at one of the facts I always found very interesting, when you look at women who have heart attacks as opposed to men, women are more likely at the time of their heart attack to have a modifiable risk factor that they're not modifying at the time of their event, which basically means they have uncontrolled high blood pressure or uncontrolled cholesterol that they're not adjusting. And we are more likely to derive benefit from the medications than a man. So it's hard and frustrating that we get so much hesitation because we will have a better result if we take medication. So, I tell patients, the average American needs over 2 medications to control their blood pressure. So yes, you may need 1 medication, and exercising, that's helping you not need 2 to 3 medications. So I try to, spin it in a way that the glass is half full as opposed to the glass is half empty.
Or put things in perspective. Like right. The reason, like you're at a lot of risk, but you haven't had a heart attack because you're doing the right things so far.
Agreed. My sister had a heart attack at 37.
Mm-hmm.
And she was a triathlete and a mother of 4 and someone that paid a lot of attention to what she ate and how she exercised and took care of herself. And I would say that it's even, I mean, it's about 5 years ago now, 4 or 5 years ago now that it happened. And she's just coming to terms with the fact that this is a lifelong thing she's going to have to deal with. I think you get really used to being able to fix your own problems. And she was definitely under a misconception that she would be able to not take meds eventually. But one thing that has really helped her is being part of support groups, the American Heart Association, being able to talk to other women that have gone through the same thing that she has, people that can understand how she feels as a mother and someone who's really busy and as a professional, and that can really relate to her on that level.
Yeah.
That's a perfect example, really. Perfect example.
Yeah, actually, I was going to say there was a question in in the chat box, and for our participants, please feel free to enter your questions, and when we get to the Q&A, we will address them here. But you guys answered that. One of the questions was, I don't want to be on my cholesterol medication anymore, and it is it's a life sentence. But that was a great answer.
I mean, I think just going back to that, I mean, one of the things that we will often do for patients, so if your cholesterol, and just getting back to cholesterol, I think we need to kind of think about, you need to know what the breakdown of your cholesterol is. So there are different components to cholesterol. There's what's called your LDL, which is your bad cholesterol. There's your HDL, which is your good cholesterol. And then there are the triglycerides, which are really the fat in your blood. Now, of the things that we can control, triglycerides are the ones that are most controllable with our lifestyle and what we're eating. Now, HDL, which is the good cholesterol, in women, we tend to have higher HDLs than men. So our HDL goal is greater than 50. Once women go through menopause, their HDLs tend to go down and go in the wrong direction. So unfortunately, 5 to 10 years after menopause, women and men's cholesterol panels get to look more similar. And so when you look at a cholesterol panel, you have to look at the ratio and how, what is, so if the cholesterol is 220, what is it, what's the actual breakdown? It's not that you want your cholesterol can be 190, but you can have a very unfavorable HDL to LDL ratio. If you have an HDL 20, that is horribly low. And so that, your cholesterol may not be high because of that, but so it's really important to understand that. And not one number is good for all, like we talked about before. But that's why it's important to know your numbers and know your numbers over time. Not like, I think Mary Kate said earlier, have a relationship and check in. You want to get your cholesterol done at least every couple of years, every few years, especially if things aren't in the right range, so you have a sense of things. Now, I do have some patients who are extremely resistant to medications and do not want to take them. And sometimes in that situation, I'll consider doing something like a coronary calcium score, which looks to see if there's plaque in their coronary arteries, or I'll look at their carotid arteries to see if there's plaque in their carotid arteries. And sometimes we'll get surprised where we'll see someone who has absolutely nothing in their carotid arteries and absolutely zero calcium score. And if their cholesterol is kind of borderline, you can say, what, let's just sit tight and watch. And there was a big study that came out just a couple of weeks ago talking about that, being able to use coronary calcium scores to sometimes help pick out who's the high risk person, but also sometimes to say who's low risk. So maybe you don't need that cholesterol medication just yet, and we can kind of hold off for a little bit. So I see a lot of women, younger women who have a family history who are worried, and they're open to medication. They're just not sure if they need it yet. And, we talk about that and we do testing and say everything looks okay, but the cholesterol's kind of borderline. I'll say, right now, not perfect. It's not ready the time to pull the trigger. Let's just, you keep living a heart healthy lifestyle, and I'll see you back in a few years. Versus the person who's like smoking or has high blood pressure, that's going to be very different. You're going to be much more likely to say, what, that LDL is not okay with these other risk factors that you're not controlling, if that makes sense.
And I also, just on that note, have, I may identify someone that's at higher risk. And a point that I want to make is that sometimes I tell them, well, let's start the Lipitor or whatever. And they're like, well, no, I'm going to stop smoking. I'm going to stop and I'm going to lose weight. And I'm a big believer in, like, you might, and your ASCVD score may change, and that's great, but I think we should protect you in the meantime. Yes. So if you come back here in a year, like 50 pounds less and a non-smoker, your ASCVD is going to look a lot better. And in some cases, we can stop your medicine, or at least reconsider. But I really, really believe that we should start you on the medicine while you're on that journey.
Right.
To protect
you. Okay. So we're talking a lot about like knowing your numbers, and when is it a good time to, you know, start assessing this? Like, do you see a primary care provider? Do you go right for, you know, a cardiology consult? Like, I mean, I don't know my numbers, so what do I do?
I mean, in an ideal world, everyone would have a primary care doctor that they had a great relationship with and were seeing for years, and that would be something that would be dealt with a primary care doctor, and that primary care doctor or provider would then, you know, triage you to Christina or me. But that's unfortunately not the lay of the land in medicine, and not, at least, you know, definitely not around here. You know, primary care docs are dealing with, you know, 7 problems in a 15-minute window and may never get to the cardiac part of it, especially if you're a 50-year-old woman. It's okay, we'll do that next year at your annual visit next year. So, you know, I feel like if your insurance pays for it, or you want to pay out of pocket for it, but if your insurance pays for it, you know, why not go to the specialist who's only focused on that issue, right? So it's not to say that the primary care providers can't do it. They can, but sometimes they're dealing with, you know, you have 6 other medical problems, you know, they're trying to deal with all of them. If you're completely healthy and have 0 medical problems, the only thing you're worried about is your heart health, and you go to your primary care doc, then they're going to focus on that. But I think, you know, I think it kind of depends on who you are. But I never think it's a bad, I mean, not just from a cardiologist, I never think it's a bad idea to see the specialist that you're worried about, that manages the condition you're worried about. And I also think we're a little bit more aggressive with pushing kind of the recommendations and stressing things in terms of, you know, lifestyle modifications and medication goals. And we're more likely to pull the trigger with saying you need to do something about this. As a general rule, I think that's the case.
Yeah, I think that, I don't know if I'm like biased, but I think it's like never a bad idea to see a heart doctor, but I am biased, so we can't go by that. But I do think that it's important for people who have a family history, especially in a first degree relative, especially if it's what we call premature CAD, like 37 years old or 35 years old, someone who had a major cardiac event at a young age, what we call premature CAD. If you have that in a first degree relative, then it's a good idea to go see a cardiologist and talk about what sort of options are available to reduce your risks. You will hear about things like a lipid panel, a calcium score, which Dr. Cuomo mentioned. It's not appropriate for everybody, but that's one thing that could be talked about. If you have any symptoms, chest pain, short of breath, palpitations, things like that, and like you said, if your insurance pays for it, I think it's a good idea to talk to a cardiologist. If not, start with your primary care. And I like to think most primary care doctors are pretty good about saying like, hey, you know, reaching out to one of us. I saw this patient in the office. Do you think she should make an appointment with you? Or, you know, and we can start with some preliminary recommendations. Why don't you order this test and I'll see her in a couple of weeks. So we like to work with primary care and get the ball rolling. So having a good relationship with a primary care doctor is a good start. And then if you have a lot of risk factors, try to get in and see a cardiologist or a nurse practitioner.
Yeah. Unfortunately, you know, what happens now is just with insurance, and people change insurance and change jobs. A lot of times they change docs, you know, or providers often. And it's, you know, the days of like having that same provider for 10 and 15 years is just unfortunately not so common. People move, there's a lot of transition in healthcare ends in people's lives. So that's challenging because you don't have that really, you know, it's rare to see patients have that really great relationship with primary care providers like they used to. You know, just as a general rule, you know, women tend, if you don't have a family history of premature coronary artery disease, and you don't have, you know, say type 1 diabetes or a lot of underlying medical conditions, women generally have cardiac issues that creep up on average about 10 years later than men. So it's around the menopausal time where women really start to have increased risk. So that's around the time I tell people that you should be considering seeing a cardiologist. You know, when the perimenopausal symptoms kick in and you're starting to have hot flashes, and that's a very common time where the palpitations start kicking in. And I see perimenopausal women all the time that don't feel well for, a lot of different issues. So that's a good time to say, let me go see a cardiologist. Or like Christina mentioned, the premature, I tell patients, if you have a premature family history of premature coronary artery disease in the first degree relative, you should be seeing a cardiologist 5 to 10 years before that person. So if your dad had a heart attack at 50, you should be seeing a cardiologist in your young 40s, because family history always kind of in our head trumps everything. If you tell me your father had a heart attack and your father's father had a heart attack and all your father's brothers had heart attacks and sisters, that tells us that you may have inherited a bad genetic predisposition, and that makes us much more concerned and more likely to do some of the screening tests, like we chatted about.
Great. So I want to just do another plug. Participants, if you guys have any questions, please drop them in the chat box for us. But one of my other questions is, so facts about aspirin. I feel like you kind of hear about, oh, I'm just going to take an aspirin and maybe for preventative measures. Can we talk a little bit about that?
So I feel bad for aspirin because it's getting a lot of flack, but in the right person, in the right patient, it actually is very helpful for reducing risks. So I think that gone are the days of, I guess it was turning 50 and starting a baby aspirin, because aspirin, it is a baby aspirin, but it's not innocent. It can cause a lot of trouble and it can cause a lot of bleeding. And if you're not the person who will benefit from aspirin, it's just going to cause problems and not help you really, because you're not at risk for it. But if you're someone who, your cardiologist identifies at risk, or maybe you've had a prior major cardiac event, aspirin can drastically reduce your risk of recurrent events. So if your cardiologist says to take aspirin, you should probably take aspirin, but don't take it otherwise. That's my input.
Right. So I think, there's been all this, it's interesting because aspirin's been in the press a lot lately. And the reason that is because the U.S. Preventative Task Force changed their formal recommendation about aspirin being used for primary prevention. And so it's very important that people understand there is a very big difference between primary prevention versus secondary prevention. So primary prevention means that you're completely healthy, no cardiovascular history, and you're taking something to prevent something from happening. That's in complete contrast to someone who's already had a stent or had a heart attack or has carotid artery disease.
Or stroke.
And stroke, right? So I can't tell you in the last 6 months, and I'm sure Christina will say the same thing, how many patients of mine have stopped their aspirin because of what they saw on TV when they have strokes and heart attacks. Like, it's like, oh my God, what are you doing?
Yeah, I'm like, they're not talking about you.
They're talking about you, right? I always say that, right? So someone's asking about aspirin on the chat. The aspirin dose we use generally is 81 milligrams of aspirin. We used to use higher dose aspirin, 325, but now almost everyone with cardiac issues get aspirin 81 milligrams. But and like what Christina was saying, it's not that aspirin doesn't help, it does help, but because of the bleeding risk associated with aspirin, it's not really meant for everybody. So it shouldn't be in the water for everyone over the age of 50. But, even though the big study that looked at aspirin that really kind of changed things had diabetics in the population, and diabetics we always routinely had on aspirin. And when they looked at those patients, they weren't having as many cardiovascular events as they had predicted, which is great, right? But the thought is that we're being much more aggressive in treating cholesterol. Our diabetes management is better. So the number of patients in that study had less, the number of patients who had heart attacks was a lot less. So it would have taken a lot more patients for aspirin to really have shown a benefit. And so that was kind of a nuance with that big trial. And that trial is what really made the U.S. Preventative Task Force change their recommendations. So I tell patients all the time, yes, you have to think these are recommendations, but you are an individual person. And so if you're smoking and you have a little bit of plaque formation and you're 60 and you're not frail and you don't have heartburn and you've never had an ulcer, I'm still going to think you should be on a baby aspirin versus someone who has, Barrett's esophagitis and they're getting reflux all the time and they're, otherwise healthy. That person shouldn't be on an aspirin. So like, again, this is where there's recommendations and then there is an individual approach and having conversations with someone who knows you and can look at you as an individual in the background of knowing the data.
We did briefly talk about autoimmune issues, but there is a question in the chat. How often should you see a cardiologist if you have sarcoidosis?
Yeah, so then there's not a right answer to that. A lot of it depends on sarcoidosis, and if your sarcoidosis has any cardiac involvement, then you need very regular cardiac follow-up. So sarcoidosis is an autoimmune disease that can have extreme varying manifestations. You can have people have asymptomatic sarcoidosis where they were found to have just a spot on their chest x-ray, to people who are extremely debilitated with multiple organs involved. So, and I'm sure Christina, we both follow patients with sarcoidosis. The cardiac sarcoid patients tend to be at increased risk. So I see them at least once a year, if not more. And I have some patients who just have sarcoid involving multiple organs, not their heart, but because they have sarcoid in their liver and in their lungs and in their brain, you're worried about them potentially developing cardiac sarcoid. So, I don't think it's a bad idea for them to be seeing a cardiologist once a year.
Yeah, I agree. Once or even twice a year with cardiac sarcoidosis, for sure. I agree.
Oh, I see another question in the.
I like this one.
Yeah, I like this one too. I'll read it. Have you identified an increase in cardiac issues for women post COVID-19 diagnosis?
Yes.
You had to know Rona was coming.
Yeah. No, and it's good.
Good that it's being asked because you can't deny that there's something.
Yeah, I mean, I don't know. Maybe Dr. Cuomo knows better than me, but I don't think there's a lot of like hard data yet that we can call on, like a increased percent or things like that. But I can tell you what we see, and we see heart attacks, arrhythmias, and a lot of blood clots everywhere, including in the arteries of your lungs and things like that. So a lot of times my consult list in the hospital will be COVID with this and COVID with these things I mentioned. So there are things that I'm seeing to begin with, things like arrhythmias and heart attacks. That's kind of my normal shtick, but it's with COVID. So yeah, I think we're definitely seeing a lot of cardiovascular effects in the presence of COVID, but I think we're going to have to sit tight for the actual data.
Right. I think, and I think, what we're seeing with COVID, right, it was like Christina said, there's no data, no one has data, but we're seeing a ton of issues, right? COVID clearly is causing a lot of inflammation and a lot of just immune system kind of craziness, dysregulation, whatever word you want to call it. But there's this profound inflammation that is being seen in, a subset of patients, a lot of them ending up in the hospital because of that. And we know that inflammation is a main contributor to plaque rupture and plaque formation. And so that kind of goes back to the autoimmune, like the lupus patients and the rheumatoid patients with all this underlying inflammation. And that inflammation that occurs with COVID probably has some, significant cardiovascular effects. And then that's in the hospital setting, but then in the office, I mean, I see patients every single day with every single day, at least one patient a day of mine is there with a post-COVID complaint. Palpitations, racing heart, short of breath, can't exercise. And these are young women who had mild COVID. I was on a telehealth with one of them today who was bawling that she can't exercise. I mean, these are, and it's clearly seen that patients with post-COVID, there's some kind of autonomic dysregulation where heart rates are all over the place. Not that you're having an arrhythmia, which is an abnormal heart rhythm. So the heart's in normal rhythm, but it's just going a lot faster and erratic, up and down, and not like where normally you run a marathon, your heart rate's racing. These are people whose hearts are just racing when they just start to exercise, so they can't keep exercising, or they're just sitting there and everyone has their Apple Watch, their Fitbit, right? So they come in and they show you, look, my heart rate was 160 and I was watching TV. And these symptoms are extremely, extremely distressing to people. And unfortunately, there's not a whole lot that we know. We try to apply different treatments or different mechanisms that we use for other times we've seen this, but it's really, it's everywhere with COVID that you're seeing people like this. The people who have severe myocarditis, right? Everyone talks about COVID myocarditis. That's very rare, right? We do, Christy and I both seen them. We've managed them in the hospital because anyone taking care of COVID patients in the hospital has seen that. That's not what the majority of people are having, but the majority of people are there are a ton of cardiac symptoms, and it's hard because you don't, as a provider, you want to help people and you want to get them to feel better, and we don't a lot of times can't make people feel better. It's like time,
Yeah, we basically spend a lot of time telling them we don't know.
Right.
A lot of patients are hoping to hear about a timeline. And some people do get better. They feel like they're never ever going to get better. And really in 3 to 6 months, they really are doing well. So a lot of times people get better. But there are people, and I'm sure Dr. Cuomo has the same patients of mine who had COVID like 2 years ago, and they're still not feeling back, and that's really devastating. And it's tough for me as a practitioner because they want to know if they're ever going to feel normal, and I really don't know, and nobody does. So we try our best to make them feel as well as we can, knowing what we know, so that they can do as much as they can in the meantime. And also, I just wanted to touch quickly on myocarditis because it's a word that nobody knew and now everybody knows. Like myocarditis is in everyone's vocabulary. And something that people I know don't seem to understand is myocarditis isn't black and white. Like Dr. Cuomo mentioned, we've seen really devastating myocarditis in the hospital in the setting of COVID, very, very sick people. But believe it or not, you can have like mild myocarditis. Mm-hmm. So there are people who get myocarditis from COVID, and everyone thinks that's really scary. It's scary, but a lot of times myocarditis can get better with the right medicines and a little bit of time and good follow-up. So myocarditis is not always the end of the world. With good management, you can have COVID myocarditis and be okay. So I just wanted to say that.
Yeah, no, that's a great question, and for some amazing response and answer there. Thank you guys for that. It just doesn't feel like it's going to go away. It keeps coming up every time. So we only have a couple minutes left. Is there anything that we haven't touched on that you ladies would like to share with our attendees?
And I think I'll go back to, as a woman, we're more in touch with our body than men, but we're more likely to ignore things when it comes to us as opposed to the people we care for in our lives. And I think that's just second nature to a lot of us. We don't even realize we're doing it. But if you don't feel right and you feel like something is going on, you should get checked out. And if you're having any symptoms, chest pain, heartburn, nausea, extreme fatigue, don't sit home. If the thought, could this be my heart, even enters your brain, seek medical care, because women are known to delay care when they're having an acute cardiac event. And every minute matters. So when someone comes into the hospital with a heart attack, the way it works is someone comes in the hospital, they're having a heart attack. they get an EKG, essentially like an alarm goes off in the hospital, and like 50 people get activated to come into the hospital and make beds. And we all drive in at, 90 miles an hour to get to the hospital because we're trying to make what's called the door to balloon time, which means we're trying to open up your artery in this period of time. And that door to balloon time is less than 90 minutes. So that's how critical it is for us to get in there and restore blood flow to your heart, whether or not it's 3 o'clock in the morning, a blizzard, or whatever's going on. So when you sit home and you think about it, that's how we want to be there less than 90 minutes. So if you're sitting home for 2 or 3 hours with your symptoms, all this time your heart's not getting enough blood supply and you're having more and more damage to the heart, your outcome, even if we restore blood flow to your heart, is not going to be the same as someone who got to the hospital right away. So my kind of plug is, if you think something is wrong, go seek medical attention, go to the hospital. I have so many people who came in the last year, especially with COVID. I didn't want to come to the ER. I didn't want to catch COVID. I didn't know. I didn't want to wait. And that delay in medical care, it just can cost you so much, both short-term and long-term. So I just kind of stress that, listen to your body and seek medical care.
Yeah, I want to expand on that too. I mean, I agree, but there's one thing that I tell, especially women in the office is, you're not crazy. And no, you should never be seeing a doctor that makes you feel like you're nuts. Okay. So your body. If something is wrong, like Dr. Cuomo said, go see your doctor. Even if you can't, you're not medically trained. A lot of women come into the office and they're trying to answer their own questions, right? They're like, well, I have this, so it must be this. And it's like, just tell me how you feel and we'll figure it out together. And I may not be able to find what's wrong, but if there's something wrong with your heart, I will find it. So you know what I mean? So I may not be able to answer it, but I will be able to make sure it's not your heart. So at the very least, we can take your heart off the table while you are on this journey to figure out what's going on with you. So like I said, if something's wrong, just keep going back. Don't let anyone make you feel like you're annoying them or you don't want to bother them. We're here to help and we're here to take care of you. And, I feel really bad when someone comes to see me in the office and I'm like, how have you been doing? And they're like, miserable. I'm like, why didn't you come in? I feel terrible. I could have helped you. We could have done some testing. We could have sorted things out. I wish you weren't just sitting at home waiting for your follow-up appointment to talk to me about how you're doing. So give me a call, come in sooner, and we'll figure it out together. You don't have to figure out anything on your own.
Right. And I think also, Christine, I tell patients all the time, listen, you're anxious, but you're also anxious and you have heart disease. Like you can have both of them. You're allowed to have both, right?
Yeah. Who doesn't have anxiety? Everybody does.
Exactly. And nowadays with COVID, everyone's anxious. I'm like, yeah, you're a little bit anxious, but you're a little bit anxious and you have a problem. Like, so it doesn't mean you can't, so that it's allowed to be both, right?
Right.
So yes, and we're all, life is very, very stressful now. And the effects of this pandemic is really showing on almost every patient of mine every single day.
Absolutely.
Yeah. Well, we do have one other additional comment here. Let's see.
I saw that over there.
Mr. Big.
Mr. Big.
I'm trying to read it.
I have a conflict of interest. I love my Pelotons.
I love mine too.
I do like mine as well. The comment is that Mr. Big on in Just Like That does have a massive heart attack after exercise. But so I guess maybe that's where the question comes from with COVID. Right.
Yeah. There was actually two questions. I think it was Regina, maybe the name, asking about exercise, as 2 questions about exercise I heard earlier up. So for women over 50, did you touch on what is considered the recommendation? So so the American Heart Association recommendation is 120 to 150 minutes of structured aerobic exercise a week. So I tell people, the people say I can't fit it in my work day. I say, okay, then do 60 minutes on Saturday and Sunday, or break it up. Try to find a way. You don't want to be saying I'm doing 5 minutes here and 5 minutes there. You really need to get your heart rate up and stay in that consistent, elevated heart rate range for a period of time. And people say, okay, well, I walk at lunch or I do this. That's not enough exercise. Not being sedentary is better than sitting at your desk, but you need really to say, okay, I'm going to dedicate this time to exercise. And, you know, going back to Mr. Big, you know, when we exercise, our heart is at increased demand because we're exercising and we need to bring oxygenated blood to our muscles. And so your heart is being asked to do more at that moment. So yes, people do have heart attacks, exercising, having sex, shoveling snow, like that. That is true. But when you look at the totality, people who exercise have less cardiovascular risk than people who don't. So yes, it's scary to see someone have a heart attack when they're exercising, but that doesn't mean you can't exercise, you know, going forward, because the overall benefit is so huge that exercising is helpful.
And I want to add, for any other Sex and the City fans out there, if you'll remember back to the original series, he already had a heart attack. So he was at very high risk
premature
of a subsequent major cardiac event. So I hope he was on the baby aspirin. That's all I can say.
Yes, I don't know how old he was then, but she was like 35 when she was taking care of him.
Right. So this was really his second event. So I just want to say that.
That's a great point. Also, I wouldn't say that we see so many people in the cath lab that are post working out that end up having a heart attack, that have an acute MI. We see far more people that are shoveling snow. So let that be your excuse to not shovel snow, not exercise.
Especially if you never exercise. People who never ever exercise ever are like, let me go shovel snow, and then they come back with chest pain.
Yes, all the time. Don't do it. Don't do it. For the interventional cardiologist on call, when there's a storm, we're like, okay, we're going to work tonight because tomorrow morning.
Snow removal, it's cheaper than a hospitalization.
Yes.
Ladies, this was so fun. Thank you guys very much for all this informative information and all the laughs. For anybody who wants to make an appointment with Dr. Cuomo, head over to the Crystal Run healthcare website. You want to make an appointment to see Christina Hahn, head over to Garnet Health Doctors. Thank you guys very much, and have a great night.
Bye, guys.
Thank you.
Okay, take care. Bye-bye.